What actually causes a painful swelling in a bone or a sudden, unexpected pathological fracture? Welcome to MedNexus. In today's explainer, we're diving deep into the pathology of bone tumors, acting as medical detectives to decode the incredibly specific clues that these abnormal proliferations leave behind. It's a huge spectrum, right? Some of these tumors are completely benign, just sort of slowly growing without causing much trouble, but others, they're highly aggressive cancers capable of rapid metastasis. So how do we tell them apart when a patient presents with a destructive lesion? Well, surprisingly, the patient's age and the exact location of that lesion are often our very best clues. Here's our roadmap for the explainer. Section 1, the diagnostic formula. Section 2, benign tumors. Section 3, malignant tumors. Section 4, metastatic lesions. Section 5, solving the case. And finally, Section 6, a radiology rapid review. Section 1, the diagnostic formula. So, here is the golden rule you absolutely need to memorize. It's a brilliant, simple formula. Age plus site plus X-ray appearance equals your probable bone tumor. You know, in orthopedics, you rarely fly blind. Just by knowing the patient's exact age and exactly where the tumor sits in the bone, you can almost always predict what you're dealing with before a biopsy is even done. It's kind of like having a cheat code. Right off the bat, we have to recognize the grand divide in bone pathology. We are constantly contrasting two totally different behavioral profiles. Benign tumors tend to be slow-growing, well-defined, and they stay put, zero metastasis. Malignant tumors, on the other hand, are highly aggressive. They literally destroy the surrounding tissue and they spread fast. Section 2, benign bone tumors. Let's profile our very first suspect, the osteochondroma. This is actually the most common benign bone tumor we see. It uniquely presents as a painless, cartilage-capped bony projection. Because it arises right near the growth plates, you're usually going to spot it in the metaphyseal region, around the knee, specifically the distal femur or proximal tibia. While it's benign, keep in mind that it can occur as multiple hereditary exostosis, and there is a rare chance of malignant transformation. Next up is the osteoid osteoma, a small, benign osteoblastic tumor that usually hits adolescents and young adults. This one has a truly classic calling card: severe nocturnal pain. But here's the crazy part. That intense night pain is miraculously relieved by simple NSAIDs, especially aspirin. Radiologically, it shows up as a tiny radiolucent nidus surrounded by a whole bunch of dense reactive sclerosis. Rounding out our benign lineup, we have enchondromas and giant cell tumors. Enchondromas are cartilage tumors hanging out within the medullary cavity, super common in the small bones of the hands. Oh, and if a patient has multiple of these, you absolutely have to consider All-Ears disease or Maffucci syndrome. Then we have the giant cell tumor. This one loves young adults and sets up shop right at the epiphysis of long bones, frequently around the knee. Under the microscope, it is packed with multinucleated giant cells, and on an X-ray, it has this iconic soap bubble appearance. Section 3, malignant bone tumors. Okay, transitioning to the really aggressive stuff. Excluding hematologic cancers, osteosarcoma is the most common primary malignant bone tumor. It's devastating because it typically targets adolescents. Clinically, they present with pain, swelling, or even a pathological fracture. It loves the metaphysis of long bones, again, the distal femur or proximal tibia. But the absolute defining pathological feature here, the malignant tumor cells actually produce osteoid. And unfortunately, it's a rapid spreader, most commonly metastasizing straight to the lungs. The destructive nature of osteosarcoma is impossible to miss on imaging. You're looking for two massive red flags. First, the sunburst appearance, which is this incredibly aggressive periosteal reaction, where the bone looks like it's literally radiating spikes outward. Second, the Codman triangle. This happens when the tumor grows so fast, it aggressively lifts the periosteum away from the bone cortex, creating a distinct triangular shadow. Our next malignant suspect is Ewing sarcoma. This is a highly malignant, small, round, blue cell tumor. It is incredibly sneaky. It typically strikes the diaphysis of long bones or the pelvis in kids and adolescents. Because it causes pain, a fever, and swelling, it frequently mimics an infection like osteomyelitis. You might think it's a bug, but it's a tumor. The giveaway is the layered periosteal reaction that looks exactly like the layers of an onion skin. For all you exam takers out there, this is absolutely crucial high-yield info. Ewing sarcoma is driven by a very specific chromosomal translocation, T1122. This genetic swap produces the EWS-FLI1 fusion gene. That single molecular driver is what sets this entire aggressive cancer into motion. Finally, for primary malignancies, we have chondrosarcoma. Unlike our last two suspects, this one typically strikes older adults. It's a cartilage-forming tumor that prefers the pelvis, the shoulder, or the ribs. A really vital clinical pearl to remember here is that chondrosarcoma is notoriously far more resistant to chemotherapy than osteosarcoma. Section 4. Metastatic bone lesions. So here is a mind-blowing fact. Most malignant bone lesions, they aren't actually primary bone tumors at all. They are metastases. They arrive from entirely outside the skeletal system. Primary cancers from the breast, prostate, lung, and renal cells love to spread to bone. When they do, they most commonly settle in the vertebrae, the pelvis, and the femur. So if you see a destructive bone lesion in an older adult, your first thought shouldn't necessarily be primary bone cancer. You need to start hunting for a primary tumor elsewhere. Section 5. Solving the case. How do we actually nail down the diagnosis in the real world? The detective work always follows a logical sequence. You start with a simple X-ray. That's always your very first investigation to spot lytic or sclerotic lesions. Then you step up to advanced imaging. MRI is incredible for judging the local tissue extent, while a CT gives you perfect cortical bone detail. Next, you run a bone scan to hunt for distant skeletal metastases. And finally, the ultimate proof, a biopsy for definitive histopathology. Once you've solved the case, treatment spans a pretty wide spectrum. For benign growths, you might just observe it or go in for curettage and excision. But for malignancies, the stakes are much higher. We're talking neoadjuvant chemotherapy, radiotherapy, and major surgery. Osteosarcoma, for instance, often requires intense limb salvage surgery. Ewing sarcoma, on the other hand, while highly aggressive, is thankfully very chemosensitive, so we hit it hard with systemic protocols. Section 6. Radiology Rapid Review. Let's lock in those high-yield visual associations before we go. If you hear sunburst pattern or Codman triangle, your brain should instantly scream osteosarcoma. If a case mentions an onion skin layered periosteal reaction, especially in a kid with a fever, that points directly to Ewing sarcoma. And if you have a young adult with a multiloculated soap bubble lesion at the epiphysis, you are undoubtedly looking at a giant cell tumor. Lock those in. And that wraps up our investigation. We've seen how age, site, and X-ray appearances come together to form the ultimate diagnostic formula. Recognizing these specific clues isn't just about acing your pathology exams. It's absolutely essential for early recognition, rapid intervention, and ultimately saving the lives and the limbs of your future patients. So, how will you use these clues the next time you look at a scan? Thanks for joining me on this explainer. Keep asking great questions, and I'll see you next time.